Well, hi, everybody. Good morning or good afternoon, depending on where you are in the country or the world. My name is Garrett Schmidt, and I am the managing editor for VBC Exhibit Hall. So I'd like to welcome you all to today's live webinar, which is the number 3 in a 4-part series called All Roads Lead to Value-Based Care, and it is sponsored by NetHealth. So very excited to hear from our speaker today, who I'll introduce briefly in a moment. Today's session is going to be about value-based care across settings, and our speaker will explain what that means, and there's going to be a lot of great information exchanged, so I'm super excited that you are all here. A few items of note before we get started. Just like the webinars we always do, this is a traditional webinar format. So you don't need to worry about muting your microphone or your camera. We can't see you. Don't worry about that. It's not like a Zoom call. But we do want to hear from you. We're going to have some time for Q&A towards the end. So if you have a question, go ahead and submit it at any time. You don't have to wait until the Q&A to do that. And we're going to get to as many of those as we can during the allotted time. And the way you do that is using your control module. That has a space for questions. So just go ahead and drop it in there, and we'll get to, again, as many if we can. If we don't get to yours, someone will reach out via email afterwards to answer it. And then finally, the session today is being recorded. So we will be sending out a link to the recording after the fact, where you can also download the slides. And this way you can rewatch it or share it with colleagues. We hope that you do that. There's a lot of, again, great information here to have. And if this is your first time joining in this series, don't be discouraged that this is part 3. You're going to be able to jump right in, and there's going to be a lot of great stuff. So you don't necessarily have to go in order with this one. And then we'll send you also the link to part 1 and 2 when we send out the thank you email later. Finally, I would like to introduce very briefly our speaker today, Miss Erica Archuleta, and she is the Payer Analytics Solution Director with NetHealth, and she's going to get us started. So welcome, Erica.
Thank you, Garrett. Thank you, everyone, for joining today. I'm really excited to do this. Today's session, we're really talking about value-based care across settings. Change my slide. There you go. The learning objectives today are really talking about the settings of hospitals, nursing facilities, and primary care, as well as really discussing some of the challenges and opportunities for all of these settings and some of the contracting provisions. So let's start this off with the first poll question today. First, I'd like to know, there we go. Do you currently participate in VBC programs with Medicare, Medicaid, commercial insurance, none, or is it not applicable? Let's take that poll question and then we'll get started.
Okay, so the question is up. I pulled it up. So you should see that on your screen. And go ahead and answer all that apply here. And this is anonymous, so no one else will see what you say, but we'll show the results here in a minute, and you'll get a chance to see what your colleagues are doing too. So we've got some results here coming in still, and we'll give it a few more seconds here. And again, the question is, do you currently participate in a value-based care program with, and select all that apply. So I think most of the reactions are in here, so I'm going to close it down in about 5 seconds here. 5, 4, 3, 2, and 1. So I'm going to close it out, and then I'm going to share the results. Erica, are you able to see these?
I'm not able to see them.
Okay, I'll read it out to you. So Medicare, we have 67%, Medicaid, 44%, commercial insurance, 56%, none is at 6%, and 17% for non-applicable.
Okay, great. That's a great combination. So good. We've got a bit of a combination today. I like to see that.
Okay.
So let's talk about settings. So let's talk about why we talk about value-based care. So first off, we kind of talk about it, especially in the context of Medicare and Medicaid, particularly because Medicare and Medicaid are probably the largest payers of the health system. As we know, about 63 million Americans rely on Medicare, and about 89 million rely on healthcare. And that was probably that number, forgive me, was probably a little bit before the public health emergency. So we're probably seeing around there at this time, where that's lying. As you know, there's the big public health unwinding. So this number is kind of fluctuating, especially in terms of Medicaid at this point. But as we've seen, is Medicare really has a really big initiative of talking about moving towards value-based care by 2030. That's really been their focus, and they've really given strong indicators to us across the board, both Medicare and Medicaid side. So we'll start by really talking about value-based care in hospitals. One of the things is that, it's really about improving that quality over quantity. And we talk about this all the time is, it's really having more return on our investment and getting better health outcomes than really just having a volume of payers. So first, let's talk about the hospital-based purchasing program. This was really an initiative that was really implemented by CMS in the Affordable Care Act. Part of this was really to encourage acute care hospitals to really improve their quality for Medicare beneficiaries. Again, this was really for Medicare. This program was really about linking the payments to quality of care and delivery rather than just a quantity of services. We looked at the objectives were really a lot about quality improvement, safety, reduction of adverse events, patient experience, evidence-based care, and really transparency. This was really what I think when I saw my career was really that this was the point of where we really started talking about transparency in terms of quality. In this particular setting, this is where Medicare really withholds about 2% of the payments from providers and then returns it on a claim-by-claim factor at the end of the rating period, depending on where they lie in the quality. What we see here a lot is that the readmissions, we see a lot of them, the measures happen to be really about the screen here, about the kind of mortality and complications, reduction of infections, patient safety, and the experience. Really, it's all of these go into the evaluation for the total scores to make this payment. And that's really where they started really, I look to this as being really the first hospital-based, value-based purchasing effort that was really made, that we really saw on a national level. Then looked at this is that we then went into the hospital readmission program. In this particular, it was really reducing avoidable readmissions, as well as really improving the communication. You really had the 30-day risks that you were really measuring. You had the AMI, you had the chronic obstructive pulmonary disease, heart failure, pneumonia, as well as the coronary graft, as well as the arthroplasty. I can never say these things correctly, but yeah, I mean, it was really, these were the measures that were really being used for this. We were really looking at the calculation that CMS used this to really calculate the payments. They capped it at 3% reduction, okay? So it was really looking at where the performance was and what the performance factor was. This, again, was really aimed to improving those outcomes, really wanting to see that the patients were really not returning to the hospital and that hospitals were really being incentivized to improve their care and really make sure that these members were really placed back into the community, back to their home, and were really improving. But really, I'd like to focus more on what we're doing right now on Medicaid. Now, I will really tell you, because Medicaid's kind of where my background comes in and really where I really have focused for a lot of my career. We've really seen in the last years Medicaid really making movement towards hospital quality improvement. I think first we really saw this with DSRIP. One of this was where states were really getting regulatory authority from Medicaid through their 1115 waiver to deliver these kind of one-time investments into their programs. They had, I know in New Mexico, we had the healthcare quality improvement initiatives that were based on our safety net care providers and our hospitals. And we really worked on domains to improve that. We've also seen some hospitals really making some healthcare performance improvements under their state plan amendments, where they've gotten authority and they kind of keep this and use a quality component that they use to take their hospital payment up to the upper payment limit using quality and performance. Now, each state is really different when it comes to Medicaid, so they use a variety of different methodologies to improve upon this. You'll see some using access, you'll see some using different different quality improvement initiatives like readmissions. You'll see a variety across the board of what they're doing, but they're really utilizing this payment to really help supplement the hospital payments with quality improvement payments. The other thing that we've really seen kind of more after kind of the end of DSRIP, which really, as CMS was starting to phase that out, really started to transition into what we call managed care directed payments. These were authorized through a 438.6 directed payment preprint. And this was really a great game changer for a lot of state Medicaid programs, because now under your managed care program, you're really building in these incentives for hospitals. You're seeing things for state teaching hospitals getting really quality payments specific to their population. You're seeing initiatives for rural hospitals, rural frontier hospitals. You're seeing initiatives for OB care, maternal health. You're seeing a variety of payments, both inpatient and outpatient under the hospital value-based payment initiatives. A lot of these tend to be, like I said, supplemental payments, because as we know, the Medicaid reimbursement rate tends to be low. And so what we do to kind of offset that when we have flexibilities is utilize additional dollars to build in quality payments for these providers. Again, for Medicaid, they're kind of subject to a UPL under their fee-for-service side of the house. So sometimes they are able to have some more flexibility, and very typically, a lot of their volume in managed care states is under their managed care component, so they have a little bit more flexibility to add in some of these payments. So that's been a real game changer for hospitals and in terms of payments and kind of revising the care. I mean, each state is very unique, but it's really, I'm impressed with what all my Medicaid colleagues have done across the country, implementing different requirements and different initiatives for their states. I think other things that they do is really using their managed care contract requirements. Sometimes they give the managed care organizations a lot of autonomy to build the payment, to build the program. I think at times prior to preprints, we definitely tried to be a little less prescriptive to the managed care organizations and tell them that we'd put some contract requirements in there and say, hey, listen, you need to really build value-based care within your contract. You have flexibility. We have the managed care organizations to task by saying, here's a percentage of your payments that we would really like for you to have into value-based care, but we gave them autonomy to work with providers to develop that. Now, I think we saw some success in that, and I think that there always is room for improvement upon that. But then I think what we did is we focused more on the directed payments, because that really gave the states authority under managed care to be a little more prescriptive and directive to these, and really build more programs that were more beneficial for both the providers as well as the payer, but really keeping all of that in mind, and ultimately really improving the outcomes for Medicaid members and recipients. So that's really where it stands for hospitals in terms of value-based payment and initiatives. Then we move on to our nursing facilities. Both short-term and long-term facilities are really key in the delivery system. As we know, very often Medicare is the primary payer of skilled nursing days, which is short-term. Long-term days very much tend to transfer into the Medicaid realm. So one of the first things you have is a skilled nursing facility value-based payment program under Medicare. This is for SNFs. This was really aimed at incentivizing skilled nursing providers to really deliver quality care. In addition, it was really the opportunity, again, for transparency, because a lot of these were used on some of the MDS and the Care Compare scores, things that were now nationally and were publicly available for providers, so that not only that other providers, but payers, the entire public could see vision into what these metrics were and the transparency of how the provider was performing. In this, the adjustment really comes from a withhold that takes place for the skilled nursing facilities, and then these dollars are then held back and then redistributed to the providers based on their performance. What we found is for the fiscal year 2024 program, the payments are based on the 30-day all-cause readmission measure, and the SNFs are evaluated both on improvement as well as improvement as well as not declining. So there's those scores as well that they are evaluated on. So that's really what they get to. They're incentivized. That's kind of like where I think we started to see some of this work started going into Medicaid as well, because that all-cause readmission really tends to impact all all payers, all settings. So really focusing on that. We see that kind of translate over into Medicaid payments as well. And I'll talk about that a little later. Next, we also have the Skilled Nursing Facility Quality Improvement Reporting Program. This was really focused on data collection, transparency, really the goal of being transparent and reporting. This really incentivized nursing facilities to be reporting, keeping their data, keeping it out there, and really allowing the beneficiaries to really make informed decisions. This was really the whole mission of what this was established under, which was IMPACT, the Improving Medicare Post-Acute Care Transformation Act. This was really standardized data exchange for the healthcare providers on really consistent quality measures. This program was really meant to incentivize for the measures and for reporting on them, as well as penalizing if you didn't report them. So this really was the incentive, and it also really incentivized continuous improvement upon the skilled nursing facilities. Again, then we go back to the Medicaid. Again, when we talk about skilled nursing facilities, they have very significant payer mix. So what we talk about here is a lot about the long-term days tend to be paid for under Medicaid. So under Medicaid, what we started to see, and you'll see this because each state is really different. You see some states really doing under their fee-for-service environment, they've obtained a state plan amendment authority to implement a quality improvement initiative for the nursing facilities. Some of them take it up to what they call the upper payment limit, allowing a supplemental payment up to that limit to really improve quality. They use it on a variety of measures, some of them a lot. We see that readmission measures, anything to keep the member, out of the hospitals, keep them healthy. Also, we see a lot of transition of care measures here. This is where we see the transition of if they're in a facility based, that are they able to transition to home and community benefit? We see a lot of those types of measures in the Medicaid realm. Again, you first saw it really under fee for service, and as managed care, and not many states, there's quite a few states that do their long-term care under managed care, but they under fee for service and managed care, they're transitioning more, as we're seeing over the years, into a managed care environment. And you're really utilizing some of these initiatives to move into managed care and do directed payments, managed care requirements. Similar to what I talked about earlier, is that we allowed the facilities, the managed care organizations, some autonomy at first, and saying, managed care, please have a certain percentage of long-term care into value-based payments and really work with providers to do that. Over time, what we really did is, as directed payments came along, we really saw the opportunity to really be more prescriptive and have more uniform programs for the facilities and for the payer. Because again, I think it's quite burdensome for providers to have multiple programs that they have to manage, not necessarily having the data and not necessarily knowing the dollars. But when we were able to allocate some dollars, we were really able to get some movement. Having anywhere, some states have a couple different programs that have a couple of different domains, meaning, some are actual like MDS data that they use, some are state, I would say, developed measures, things that they want to do in each respective state that are important to their population to really improve value-based payments. You'll see staffing, but we've really done a lot more work around kind of building win-win programs for the payers as well as the providers to really understand where they stand in the payment and know that we have dollars allocated to value-based payments. So very often these really are what you would call pay for performance, and additional add-ons. So often they're not necessarily at risk. There are some scenarios that, obviously if you don't meet those respective quality measures, the payment is definitely, at risk. So, there's a mixture of designs. And again, each state has the different autonomy and flexibility to develop it as they need and as their stakeholders need it to be engaged. Then we go into primary care and value-based. Now, this is really big. Now, I think this has really been something that we've seen a lot of movement, especially with the development of the Innovation Center at CMS. I think this is really going to be an emphasis of what we've talked about is preventative care, keeping, patients healthy and really detecting any type of health issues early on. And that's really what the primary care model has really been based upon, as well as the integration with the other care settings. Again, all of these care settings really integrate with one another, are really, they have to integrate. We have a very complex healthcare system and a complex member population. So all of these really have to interact. But to begin with, it all really starts with primary care. So I'm really excited to see what we've done with primary care in terms of value-based care. I think the first time is we saw MIPS. So MIPS is a program within the quality payment framework that really is the mechanism to really incentivize providers to really come up with these value-based care initiatives. This really at first was really focused on the Medicare population. They do have an opportunity to earn adjustments on their Medicare payments, and the adjustments can be either positive or negative or even neutral. A lot of the performance quality categories here really were both quality, focusing on the quality of care provided to patients, also cost, really assessing the cost and including, the resources, how are you utilizing your resources. Also, we saw improvement activities as some of the categories. It's really what efforts are you as a clinical care clinician really doing? What kind of processes are you doing? What type of patient engagement and what kind of care are you providing? We also saw something which I thought was a little different than when we saw MIPS, was really the interoperability. This was really where we really started to say data, health information, the exchange was really important and it really needed to be incentivized. To me, I really thought this is where it key to me for MIPS is really that promoting that interoperability. Within the MIPS program, we happen to have 3 different reporting options. First is the traditional MIPS, which is you select the quality measures and the improvement activities that you'll collect and you'll report on, and you will submit them, and CMS will calculate them and calculate the category for you. You also saw the alternate payment performance model, and it's more streamlined for clinicians. It was really designed to really reduce the reporting burden, because what we find with any of these is that the burden for providers really comes from that reporting. Again, clinicians are really meant to be with patients with doing that. They have to have a really strong administrative side of the house as well in order to make these work. It's very important. And so I think when these first came out, it was a little bit administratively burdensome. And over time, there's been a lot of work to really streamline and take away, hearing the providers, hearing the burden that they incur with these, and really working to streamline them. So this APP was really about, the performance pathways, kind of having some different predetermined, the measure sets and kind of streamlining things. We then now, which I'm excited about, is the MIPS value-based pathways, the MVPs. I actually sat on a conference call yesterday and was really excited to see some of the movement here. Really what we're seeing is now in 2023, we'll see kind of the transition and the phase out of traditional MIPS and more movement into the MVPs. We'll be collecting the data for 2023. Providers kind of get to select and collect and report on a reduced number of quality measures and improvement activities. They're also going to report on their what they've done to promoting interoperability measure set. So it's really about kind of streamlining and really focusing on those domains of interoperability again. And again, having some different opportunities for providers. As we kind of move along this VBC journey, I think we've really learned that there needs to be some different measures and different promotions, and being able to really figure out how we can best integrate that and make it, less burdensome for providers. The next one I'm really excited about. Now, this one really kind of hits close to me, again, is making care primary. This is really something that I really have been excited about, because this is something where you're not only integrating, it's not for just Medicare. It's really integrating that payer set between Medicare, Medicaid, and all payers. Really what you're seeing is some different opportunities for providers and that integration of value-based care amongst, all payer sets. I think, again, this one is really excited for me because, again, I reside in New Mexico. So when I saw this and see that New Mexico was a part of it, along with Colorado, North Carolina, New Jersey, New York, Minnesota, Massachusetts, and Washington, this is really exciting to me. This program actually really builds on the Comprehensive Primary Care Plus and the models. This is really aimed to improve the beneficiaries by really supporting advanced primary care system. It's really looking at a pathway for even smaller and independent providers to really be able to start to get their feet wet in this value-based care journey and really providing them different opportunities on where they are along the spectrum. This is really a great kind of integration of population-based payments that we're really looking at. We're looking at the really big, which I think is really important, is the integration of behavioral health into primary care, because I think that's a really key component of primary care. I think it's also really big that they're integrating specialty care in this and really driving that equitable access. And when we say the states are participating in it, what I mean is like these state Medicaid agencies are really taking a lead in these programs and really attempting to bring home the stakeholders, bring together everyone from primary care clinicians, the specialists, social services providers, behavioral health clinicians, really working to develop systems that can really integrate primary care, equitable health, address population health, social determinants of health. And what's really great about this is that there's different tracks. Again, there's providers, especially in rural states, that really are starting at that infrastructure where they just need to build infrastructure. They need to get some capacity building. They need to be able to build their delivery system in terms of just technology exchange, being able to have some relationships and different assistance from, care coordination with other providers within their community. So it really gives that track one, gives you some opportunity to build infrastructure and address some of those issues. Then I think what you really say is that you're advancing it. Now, what you're looking at in track two is you're implementing advanced primary care, where you're really looking at implementing a little more robust of a system. It's track one, and it's also taking on some additional payment where you're looking at not just some incentive payment. Now you're looking at some shift to some different risk areas that you're able to take, some population-based payments. You're looking at kind of a blend of some prospective payments. And you're also just providing some additional financial support as you integrate these systems. I think that's really key, is just integrating and allowing providers to move along that care continuum on where they stand in terms of, do you need infrastructure? Are you at a track two where you need a little more support that you can take on and assume more risks with your patients and some shared savings? And then I think that you're looking at, track three, where really you're looking at really optimizing your full your payment structure. You're optimizing your population-based payments. You're really offering some additional support for your activities. You're really working to a lot more risk and a lot more shift in payment, alternate payment models. I think across the board, this really gives really great opportunity as we start to really look at these alternate payment models and what kind of support that the providers really need to reduce their payment, to really move along the continuum and shift from that traditional fee-for-service and really be able to move into those different payment methodologies, but also just a really integrated care. I think that's really important, is to have, at the end of the day, that integrative care and being able to have all of the support necessary on where they lie within that. So, prior to this, Medicare or Medicaid, I would say, we had different methodologies that we were really using to test the value-based payment models. One of the things that we had really started out doing was our 1115 waivers, where we really had some patient-centered medical homes that we were doing. We're offering, that was really the primary care of being able to have some of these initiatives where a coordinated care for members. It wasn't necessarily for all the members. There's sometimes they were targeting high-risk members. I think you also had states really looking at some bundled payments that they were utilizing under their state plan. They were looking at different models of how to reimburse primary care. I think we really started to evolve over time. What we saw was like comprehensive primary care plus we implemented as well at different approaches, where that was really where CMMI, which is the CMS Innovation Center, was really working to bridge those gaps between the payers. I think we also see in Medicaid, when it comes to primary care, that accountable care organization starting to take off. You saw some states really shifting, because traditionally many states were fee for service. It was always run that way. And over time, we've seen more and more states moved into managed care or accountable care organizations, things that were able to really do more wraparound services for members rather than just fee for service. You were starting to see care coordination come about through this. You were working to incentivize payers and all the providers to really engage in this and working in your domains of how can we really support this so that you had better outcomes and more value-based payment. We also saw we would leverage managed care contract requirements. Historically, we weren't always prescriptive in the contract requirements, allowing kind of managed care to have a little autonomy with the providers. But over time, there was really more that were being more prescriptive over time. I think we started to see this, after 2014, 2015, we've seen gradual changes over time as it keeps evolving over the last decade, right? We're starting to understand the performance and why this is important and why measures are important. And these were the types of things you started to really implement more and more, but giving you a lot of flexibility to adapt and really tailor to each state's specific needs and their population, and just what their population, if you're a highly rural state, where that stands, and having a lot more flexibility. I think then when you saw late in about when it was 2018, late-ish, when the managed care final rule finally came out and was kind of implemented, that's where we really started to see a lot more of the managed care directed payments, which are more prescriptive. We started to see that they really got into that more granular, here's the measures. You're starting to see a lot more consistency along, and you're seeing Medicaid agencies really make a strong investment into working with the stakeholders, both either their managed care organizations, their primary care providers, all of their stakeholders, to really develop these programs for the better of the good of all their members. So it's a lot, right? Like there's a lot of flexibility. There's some requirements. Primary care, there's a lot going on just in managed care on what we need, because again, each population tends to be a little different and there's a little bit different of an approach. Wow, with all of that, as I said, a mouthful. All of these are quite dynamic programs. There are a lot of challenges and there's a lot of opportunities for providers. I think it's keeping it that at the end of the day, I think providers really want to have really good service to the members, to all the clients, to all the beneficiaries. I think that we also want to see quality and value in care. I think we want to see costs going down. But with that, there becomes some challenges. So let's talk about that. I think when we talk about providers, I don't know if you're working on the Medicare side, the commercial side, the Medicaid side, there's a lot of financial uncertainty. I mean, think all of these systems have different payment methodologies, whether you were trying to build in fee-for-service, HCPCS, and CPT codes, or you're in a nursing facility, in a facility-based setting where you're billing rev codes, or you're talking in hospitals where you're talking about the DRG, the OPPS, the IPPS, all the different systems. There's a lot of uncertainty when you start to make some of these transitions. But what do we need for that? They also have the challenge because a lot of these systems aren't necessarily technology savvy. Yeah, there's a lot of great movement that's been made in technology, in the EHR, and the health information exchange, but really there was a lot of challenges for providers because not everyone is on that same playing field. So there's a complete spectrum of things, and it's being able to meet providers where they are, and so that's a challenge for them. It's also really their risk adjustment. How do they really assess their risk? What are fair reimbursement for this? What are some of the systems that they can really adjust for in their particular populations? Also, reporting. Reporting is very burdensome. I mean, I think that there's a time, again, doctors practice medicine, and again, a lot of this comes from the EHR. You're talking about there's different text specifications for each of these quality reporting measures. It's being able to look at that, having someone that can meet those requirements to either submitting it to CMS, making sure it's publicly reported data is really submitted on time, being able to ensure that they're able to kind of gauge their quality metrics. I've always said the success to value-based care is that it's really hard when there's surprises. It's hard to say if you're really thinking you're high performing, but then in the data you don't necessarily know that. So I think that's very challenging for providers as well. I think providers are also really resource constraints. I think what we really know is that staffing is going, is very challenging. The finances are really, are becoming, more limited. Training, having care coordinators available, having a system that you're able to integrate, that you have all of the necessary components in order to make a quality-based program and really be able to engage that and implement that. I think also care coordination, there's a lot of challenges. Are care coordinators available? There's a spectrum of care coordination from, lining, nurse clinicians that need to work on the coordination of care, all the way down to those population health measures of even working with, your community health workers, because they're essential into the care coordination. There's a huge spectrum of need on the care coordination. So it's having challenges really being able to align that in your particular setting and having those resources available. But on the bright side, where there's every challenge, there's also opportunity. I think here it's that once you get past that uncertainty, value-based care can really help providers manage their care, especially in some settings when you have a set income of a PMPM, or you really know that you have a set amount of a panel. You're really able to look at what your expenditures and costs are, that you're able to gauge that. Once you really get a grasp on what your quality improvement is, you're really able to understand where you stand in the quality improvement spectrum, that you're getting incentivized for performing well, or you're also getting incentivized to improve where you need to be. I think that's a really great opportunity for providers. I think you also have a patient-centered care approach, where now in a value-based setting, rather than just see them when they're sick, these types of things, you're really able to kind of get a more of an approach of patient-centered primary care. You're really able to do the wraparound services here, and you're able to do that once you kind of figure out where you are on the spectrum and how you can really engage that. I think you also have the opportunity here is population health. I think there's really, you can proactively address the needs of your community, the needs of your membership, being able to really lead some of the initiatives for really better health outcomes within the entire population. I think it also encourages a lot of collaboration between the providers. This really is a great place where once you have a value-based care, this is the opportunity where hospitalists and primary care and specialists in behavioral health are all really able to come together a little more proactively for a member, and we're able to see some better outcomes. I think that's really the key, and that's the opportunity, is being able to collaborate and integrate so that everyone is able to really work on the situation and being able to really have an integrated delivery. I think it also really leads for really great opportunities of innovations. I think this is where we're seeing telehealth the utilization of telehealth. I mean, I look at this in nursing facility settings of, if you have a member and they're able to have access to telehealth and you're able to build that into your system, that's really great. I think it's also being able to have, that technology, that data information exchange with the EHR. I think the health information exchange, really having some opportunities that we can make investments into these innovations are really great opportunities for providers. I know at first it seems to be a little bit burdensome for providers, but over time, I really think that the innovation really will be helpful for everyone. So let's talk about that. Let's have our next poll question. Do you currently have a data exchange and/or technology infrastructure strategy in your VBC contract?
Okay, I have pulled up the question. So again, this is just select one. So we'll give it a few seconds for folks to put in their answers. And again, it's, do you currently have a data exchange strategy and/or data intermediary in your value-based care contract? And the results are still coming in. Okay, I think most people have answered. So I'm going to go ahead and close it down in about 5, 4, 3, 2, and 1. And I'm going to go ahead and share the results.
All right.
Okay, the results are, we had 47% yes, 20% no, and then 33% it was not applicable.
Okay, good. That's a good mix. So I'm glad to see that 47% really have that data exchange, because I think that the key to any value-based care is that data exchange and having that technology infrastructure. What I mean by that is either, speaking with you as having, what are the sources of truth for our data? Do we have an intermediary in between that we really submit this data, that it's being calculated, that we all know where we stand, that it's transparent, that we don't necessarily see it? So I'm really happy to see that there's some exchange in there, because again, I think that is the foundation for where we move on value-based care. So next topic, really thinking about that as we move forward in this, really, what are some of the contracting, provisions? I think this is really key in value-based care, is being able for both payers and providers to carefully review and negotiate this to really align the goals, the capabilities, and the commitment to delivering value-based care. Because again, it's really a relationship with all the stakeholders. I mean, I think that to have the patient outcomes, yes, you definitely have to have the patient engaged, but I think it all really starts with, are the payer and the provider really having a good relationship and engagement as they contract, and do they know where they stand to really align these and to align the different plans? Again, there's so many plans, and looking at providers are dealing with Medicare, they're dealing with Medicare Advantage, they're dealing with Medicaid fee-for-service, Medicaid managed care, you're also dealing with commercial health. So there's a lot of provisions and a lot of things that providers have to think about when they're going. So anytime that providers and payers can come together to kind of work on these provisions and kind of think about how we can collaboratively work, knowing that providers definitely have a lot of responsibility because they have multi payers that they have to kind of navigate through. I think one of the provisions is the financial terms and the payments. Again, when you talk about VBC, is it pay for performance? Is it a capitated rate? Is it a shared savings? Where do we stand in that, and what can we expect? Because I think that is a key to making value-based care successful, is knowing, again, that providers can be sustainable on these payment methodologies and what the terms for reimbursement are. Will you be doing still some fee for service? Because if we don't have this kind of payer mix and kind of payer understandings, the payer system for VBC itself can't be successful, because we can't make providers sustainable. I also think that we have to really think about the quality metrics. Really talking about that is, what is enough? What is too many? What are we really having is the right number of quality and performance metrics? Are we covering the patient outcomes? Are we covering preventative care, chronic disease management? But also keeping in mind is that you also have to kind of keep what about those patient satisfaction metrics, care coordination. Those are all the metrics that we have to kind of think about in this provision, but not overwhelming the contract that it's not attainable. So it's really having it very specifically outlined and having just the right amount so that you can allow the providers to really focus on doing what they do well, but yet still having those really good, outcomes. Also, what kind of improvement initiatives can we have? Because I think that we have to incentivize, continuous quality improvement initiatives. I don't think it's ever good. I think some providers, they get disincentivized for improving really well or performing really well because, the next year things kind of change a little bit. They are still performing great, but it's having those initiatives, but not disincentivizing quality improvement or, disincentivizing where they stand for having good quality. So it's having that right balance between the quality improvement and well as it's just performing highly. So I think it's that really important to think about. Again, I've been in situations where we've had some providers were really performing really well. The next year they went down a point. Well, on the national spectrum, they were still really performing great. They were in the best tier, they were above average, but they may have gone down a little bit. But thinking of that in mind, that wasn't to disincentivize them for performing well. And I know that's a lot of discussion I've seen when we've been in some contracts and even designing these programs. Also, what kind of performance improvement and your ongoing care that you're going to really improve upon and incentivize. Again, it's all about the incentives and improvement, and just being able to perform where you are well, and always being incentivized for performing well. Care coordination, I think that's really also the big thing, is really encouraging providers to have that care coordination. And what does that look like? I think that we need to look at a lot how we're integrating kind of the peer support workers, community health workers, any of those types of things, anything up to the nurse to coordinate that care from providers, and having this engagement in the contract and allowing that, because very often we had some care coordination. I know when I've worked with VBC programs, we always said care coordination was an administrative cost. And I think what we're starting to see now more is that we're starting to reimburse for care coordination, and what does that look like? So working with providers to really understand what that reimbursement is and what some of the regulations around that are. I think as we're seeing some of these models come out, we're definitely seeing more opportunities for reimbursement under the care coordination realm. So I think that's very exciting, but ultimately it's really meant to improve the efforts with providers in engaging, but really how do we benefit that? I think we've also seen some contracting provisions where I've seen where we've added some codes for doctor to doctor interaction as they transition these providers or these patients amongst providers, so they're getting incentivized. And how can we really build that into the contract, and what is that covering? And also really building in those population health management strategies. Those are key. Again, health screenings, those social determinants of health, and that's a really big thing into your contract, is having those opportunities that you're building in, what those assessments are, and that you understand where we stand and how important that is to the overall system of value-based care. I think also network adequacy. I think that is really very key. I know those are a lot of measures, right? We look at, the Medicaid realm, there's network adequacy, and it's always about access. What does that mean? Is how many providers, how timely are the appointments? I think really in provision is really that network adequacy is really about that access to care. So I think that's a very key component to the contracting. I know a lot of providers get incentivized for adding some additional hours, some late night hours, sometimes some Saturdays, but building those into your contracts so that those are some key characteristics of what value-based care is. I think data sharing, I can't stress this one enough. I think there should be no surprises. And I think being able to share the data accurately analyze it, accurately report on it is really a key factor to the contracting provision. You know, often there's times for the data, a data intermediary into the data for the contracts, because again, it is really big, an important component. Also, the risk adjustment, that's very important of being able to assess for that. And the patient engagement and experience. I think that is really key, is because you're looking at your CCAPs, you're looking at different measures to ensure that the patients, that they're getting a really quality experience, and they're able to, you know, engage. So I think I've said a lot, too much today, but you know, that's all I really have, other than it's a really complex system. There's a lot of factors, and all stakeholders have to be at the table for this.
Wonderful. Well, thank you, Erica. Gosh, there's a lot there, and we do have some audience questions coming in. So if you have a question, go ahead and submit it now. We're going to get to as many of those as we can. First question here is, how are social determinants of health incorporated into the care planning process?
Oh, that's key. I think right now you're looking at screenings. A lot of the screenings, a lot of the assessments that we're working on is really the training of the healthcare care professionals to really be able to do these assessments. I think that's really the key that we're really seeing it right now. That housing stability, the food insecurity, those are really big things that they're assessing, and they're building standardized tools, as well as the collaboration with the community organizations. I think what you're seeing right now is a lot of community organizations coming together to have like a uniform resource, if that makes sense, to really address this and these social determinants, because that is one of the key drivers we're seeing from CMS, especially on the Medicaid end, is those social determinants of health.
Yeah, that's a great answer. Okay, next question here is, can you provide any examples of quality metrics that primary care can focus on to drive value-based care for the Medicaid population?
Access, access, access. So I look at your access standards. If you look at a Medicaid population, the key to Medicaid is really talking about access and those appointments. How soon are you able to get those appointments? So I think if you talk about some of the measures, first off would be access of appointments and availability of appointments and actual distance. So having some different settings, like some primary care do some remote kind of like clinical settings that they're able to have. That's key. I think you're also seeing your basics of your immunization, your chronic care management. Remember, typically your Medicaid population tends to be children. Now you have an expansion population. So your FSTAT population, you're really looking at those child immunizations, those visits, and those wild child checkups. And then as you get with your other populations, looking at those chronic disease management, diabetes control, as well as those behavioral health screenings. That's a really big key, I think, for primary care now, is that behavioral health screenings as well. So those would be some of the things I would suggest.
Those are great. Okay, next question here is, how are readmission rates being addressed and reduced as part of value-based care efforts?
Well, I think that's a really good question. I think really what you're talking about is, are you able to give them the support in order to reduce those readmissions? It's really having that care plan. It's really being able to address them as being able to, why were they back into the hospital? Were they having some early planning for that discharge? I think it's really the predictive modeling and analytics as well. I think it's they're really being addressed there's a lot of predictive modeling going on with AI and machine learning about being able to identify these patients who are needed to be discharged and having that transition plan. Also, those post-discharge follow-ups, I think that's really key. That's actually one of the measures putting on there, is really addressing those post-discharge follow-ups, those 7 days, those 30 days, as well as those medication management. That's really key of what you're seeing, is how we're addressing them, is those follow-up appointments.
Yeah, good point. Next question here, and this is probably the last one that we have time for, is what strategies can skilled nursing facilities employ to demonstrate and improve the cost effectiveness of their services in a value-based care system?
Quality. I say this: data. You're transparent, right? So I think it's being able to watch those metrics, really having a pulse on your metrics. I think having, you have to submit that MDS data, right? It's mandatory. Being able to have that, being able to have your data analytics and your predictive modeling for your measures, but being able to, in the transparent realm, be able to show that and seeing what kind of initiatives that you have, your clinical excellence, as well as your staffing models. What are you doing to retain your staff and maintain an excellence so you have a real continuity of care amongst your members? I think that's really key, but I also think it really lies in the data, showing that you are working on your quality measures and that you're aware of them, that you really know where you stand.
Yeah, that's great. And a quick follow-up to that actually question is, how can those skilled nursing facilities maybe showcase their value and expertise, positioning themselves as preferred partners?
I think, again, the quality metrics, I think it's really coming in is that you're watching your metrics, that you can come in and show, this is how we're improving, this is how we're currently performing, and this is how we're improving. And this is what we're doing to monitor our members, right? Like, they really can look at their models, their systems can really, if analyzed well and used properly, they have a lot of opportunity with their data, because it's mandatory that they do the MDS data, right? That they can be watching that and see where a member and some of the predictive modeling for these members are with some of their tools that they have. Also, those quality, continuous quality improvement initiatives, like what are you doing to continuously refine your processes? I think that's really what they can do to showcase it and showing we have this data. Because the one thing about, nursing facilities is they have a lot of data that they have to report on. They're data driven, right? So with that data, how are we utilizing that data that we have? And that's how they can showcase it, by utilizing it and really being transparent with it and working to address their areas.
Data.
Data. I can't speak data and access. Those are my two things today. If you took away anything, data and access.
Data and access. Well, that's a great place to wrap up. And unfortunately, we don't have any more time for questions. But if you did have a question, go ahead and submit it, and we're going to get back to you through email. So even if we're wrapping up here at the last minute, go ahead and drop that question in. And as we close out, I'd like to encourage you all to head over to VBC Exhibit Hall and visit the Net Health exhibit booth there. And actually, Erica, I think we had a slide on that.
Yes. Oh, super. Yes. I'm sorry. I got it. Yes, I have it. And it's in the slide deck as well. So my apologies.
No worries.
I turned it.
While she's doing that, basically what it is there's a virtual exhibit hall that they are exhibiting in, and which is with my company, VBC Exhibit Hall. And there's a lot of wonderful resources there, and then you can read up on them. There you go. And this is kind of what it looks like. And on the slides, we'll actually have a direct link to go over there, or you can just visit vbcexhibithall.com. But you can really see what they're doing in the space, just educate yourself on their different services and how they can help, and also reach out to them, of course, through there. And if you'd like to reach out directly, feel free to do that. If you go to the last slide, Erica.
There you go.
There we go. So you can reach out to Erica directly here, or feel free to contact me. I'm happy to facilitate an introduction for you if that's easier. But thank you again so much for joining us. Thank you, Erica, for a very informative presentation, and I appreciate the time you put into that. And to you all, hope you have a wonderful rest of your week and a happy Thanksgiving coming up. And we'll see you at part 4. Coming up here soon. So you'll get more information on that shortly. So have a great one, folks. Thank you so much.
Hey.